G'day everyone. Welcome back to the How I Rehab podcast. My name's Nick Kane. Thanks for tuning in. We've got a fantastic guest for you today in Dr. Rich Willy, and we'll be talking to the navicular bone stress injuries in a fair bit of detail with Rich. It gives us some great insights. Before we do want to start moving through the podcast and formalities, I just want to take a moment to acknowledge the traditional owners of the land here in Australia and where I am recording this podcast, and that's the Wurundjeri people, and pay their respects to the elders past, present and emerging. Dr. Rich Willy, for those who don't know, is Associate Professor in Physical Therapy at the University of Ohio State, and that's previously Montana. Just started there at Ohio State. He's the director of the Montana Running Lab. He's got a PhD studying patellofemoral pain. He's been a clinician for over 20 years, and in that time has taken a real interest and published extensively in running-related injuries, from overuse injuries, bone stress, and around the knee. So he's consulted with many organisations, including Olympic sports and many of the NBA teams, on these type of injuries. We found the chat, really insightful. For those who don't know, Rich is speaking at our future upcoming course, which is the 17th and 18th of October in Boston. At Fast Track the Injured Runner, be held at New Balance track facility alongside some other amazing presenters and the like, which Rich talks to. That's selling quickly. Less than half of the spots remaining to that event. So looking forward to connecting with our US audience there and catching up and experiencing a really good couple of days. We've also recently released the knee acute to capacity, and that's in Melbourne, early Feb. And after a bit of change with Michael Giacomis and his role within the Premier League, his Melbourne event has now shifted to mid-November. So that's newly released mid-November, and we'll be bringing something to Perth as well later this year. So plenty on the event side. Check it out at SportsMap. And of course, don't miss some of the masterclasses. And just to reference, Adam Castrigan around bone stress, talking to a similar sort of concept to what we're chatting with Richard today, is a really valuable resource to view, maybe following on from this podcast. So I think that's it from me from an introduction. Appreciate you guys all listening and tuning in and supporting SportsMap in any way. If you're just reading, listening, watching, we're happy to have you along for the journey and hopefully providing some great information that helps you all in your day-to-day practice and what you're doing with your athletes and patients. So we appreciate your support. And thanks again for some of our sponsors, which are mentioned throughout this event. They keep this podcast ticking along. So thanks to all, and please enjoy this chat with Rich. Okay, Rich Willy, welcome to the How I Rehab podcast.
Oh, hi, Nick. Thanks a lot for having me. I'm excited to be here.
Mate, very excited to have you. I've wanted to try to get you on this podcast for a while to chat, anything from around the areas you really specialise in, from bone stress to patellofemoral joints to running injuries and the nature. But today we're going to delve into the navicular stress injury, largely because I was going to ask a few questions around a range of things, but just found myself preparing questions and I couldn't get away from the navicular sort of scenario. So we'll just nail that down today in today's podcast. But before we move through that, I always like to let our guests hear about you and your career a little bit and what you're doing. And you've had a bit of a recent change in the career status as well in recent times.
Yeah, that's correct. So I've been at the University of Montana in the School of Physical Therapy for the last 8 years. And this fall, September 1st, I'm joining Ohio State University and coming on as an associate professor in the School of Health and Rehab Sciences with a secondary appointment in physical therapy. So yeah, it's a big move and big change, and I'm super excited for it. I'm excited to work with the orthopedic surgeons and the clinicians at Ohio State, and should be a great opportunity to do some bigger and larger work. So I'm excited for it.
Mate, that's really cool. Congratulations on the new role. Where does your interest come in running injuries and some of those pathologies and injuries I mentioned?
Yeah, well, I've been a runner, I don't know, almost my whole life, and so I personally haven't had any bone stress injuries, but my brother, who's a runner, has had several, and I thought that was kind of interesting in that he growing up, he tended to get bone stress injuries and I didn't. And then, moving on, and, I went to physical therapy school and was a clinician for a while, and I started working more and more with runners. And so, I don't know, kind of historically, we've kind of back when I was, I guess a young or new clinician, PTs didn't have a big role when it came to working with people who had bone stress injuries. Kind of just saw it as a fracture and needed to heal. And then once people healed up, then we kind of gave them a return to run program, and then that was kind of it. But I think what you've seen lately is the culmination of many years of research that is now starting to give us some real tangible evidence and tangible guidelines for not just the treatment of these injuries, but also the prevention of them. And the primary prevention of these injuries is really important because some really nice data that is showing that once you get your first one, you have a 6 to 7 times greater risk of having a subsequent one. It's not that first stress fracture increases your risk. It's just that those underlying risk factors are still present. They haven't been addressed. And because of that, you're greater likelihood of getting a second one. So the prevention part has really kind of come a long way. The treatment has as well. For me and where I am in my career, when I was at the University of Montana, I was working with a lot of ultra runners, a lot of track athletes, and I started working a lot with basketball and volleyball and some other jumping sports. And I think these injuries are just a really nice. They're very complex. It's a combination of biomechanics, of course, and then also from a physiology standpoint. So the athlete has to have a sufficient physiology to support healing and to support bone turnover. Nutrition, which is part of the physiology. Adequate sex hormone balance. That's also quite important. And there's a really strong psychological component as well. Bone adapts quite slowly, and unfortunately, a lot of our risk factors are kind of set in like peri-adolescence, if you will. So that's when our skeleton is growing the most. That's when it's most adaptable to applied load. So that's when, playing ball sports is really critical. Having adequate fueling for athletes in their preteen and also teen years is really important when it comes to having an adequately strong skeleton, if you will. But still, with that said, we can still do a lot with the older athlete. And then when I mean a bit older, of course, adult athlete when it comes to improving their ability to heal. So for me, I got my start working with runners who had patellofemoral pain and tendinopathies. And I've always really enjoyed working with those athletes. And I've always found them to be really challenging. And so my background is in biomechanics. I've been a clinician for 25 years, and I worked as a PT for 8 years before I'm back for my PhD. And so I started off working with athletes who had patellofemoral pain, but I kind of started seeing more and more bone stress injuries, and I just kind of found them to be really interesting and kind of exciting athlete to work with. And I felt like no two bone stress injuries the same. And I think that has a lot to do with just the individual athlete, but also the different anatomical sites. Like you have to treat navicular BSI quite a bit differently than say like a fibular BSI or a femoral neck bone stress injury. So where I am in my career, I think those are some advanced skills. And for me, anybody who's been doing anything for quite a while, you're always looking for new challenges. And I think this is an area where it kind of brings together a lot of my skills.
Yeah, lovely. I think we sort of certainly highlights the importance there of what we're doing with the adolescent athletes and how that may play a risk factor in future sort of injuries and bone stress. And then, yes, certainly the complexity with bone stress, which I think maybe is where some of us us as clinicians find it really difficult because they are all different. And as you said there, navicular to a femoral to a tibia, like what you're doing is probably going to be quite different. So we're going to nail down on the navicular space today. But I guess you are chatting. You're joining us in Boston for Fast Track the Injured Runner event around running injuries and speaking to these topics. We did have you in LA a year or so ago at another event for us, which was at the Intuit Dome, which was tremendous insights and having you there. So we're really looking forward to this one. What can we expect to hear from you? And I guess knowing some of the other speakers, like what are you excited about?
Yeah, I mean, well, first off, the facility is going to be amazing. It's going to be at the New Balance track, which should be a great venue. I think we're bringing together a really great group of experts. We have, Brian Heiderscheit, who we've already spoken with, Rebecca McConville, who I think is one of the best registered dietitians around. She works with most of my athletes, so I refer a lot to her, and she's instrumental in not just working with the athlete, but also working with me and how I can kind of make my rehabilitation protocol kind of sync the best with her nutritional advice and guidance. And so, I know she's going to be speaking a lot about not just what she does, but also how we as physical therapists can work the best with registered dietitians and when to refer out. And I think you'll probably hear from her. It's much better to refer a lot earlier than we probably are. So we've got some other great speakers as well. Dan Cobian, for instance, is going to be speaking on return to run after ACL. And for me, I'll be talking about patellofemoral pain and also be talking about bone stress injuries. So I'll be talking about how to treat some very basic ones such as tibia and metatarsal bone stress injuries, but also some of the more complex ones such as navicular. So it should be a great event. I think it'll provide a really nice. I think it'll provide something for every clinician of every level. So I think if you're the advanced clinician, you're going to have the opportunity to see some really advanced skills and gain some knowledge there. And I think if you're relatively new clinician when it comes to treating some of these injuries, there's going to be something there for you as well. So we'll do have a lot of workshops and not just lectures as well. So everything should be a great event. So I'm really looking forward to it.
Cool. Yeah. No. Well said. I think it sounds. Fun, interactive, and practical, and just looking forward to sort of being around those presenters and feeding off their knowledge and energy across a couple of days. So, looking forward to it. All right, well, naviculars, tell us, I guess, in general terms, why are the navicular injuries so problematic? And I'm talking here to, I guess, our overuse type injuries. We won't talk to the acute injury, which can happen.
Yeah, the more acute traumatic. Yeah, of course. Yeah, we'll leave those out. Yeah, these are really kind of very challenging injuries, and I think a big part of it is that our navicular is the keystone of the midfoot, and so it deals with a lot of compressive and tensile loads, but also torsional loads as well. So the loads of the navicular experiences during running and jumping and cutting are quite complex, and I don't think we really understand those. The tibia is, from a biomechanical standpoint, is really easy to model with finite element modeling and other motion capture techniques. The navicular is quite a bit more complex. I think we're really starting to kind of gain a much better understanding of these loads this navicular is undergoing now that we're starting to get some more advanced imaging techniques such as dual fluoroscopy, which allows us to image these very small, tarsals in 3 dimensions when someone's doing walking or running activities. And so that's helping us understand those midfoot biomechanics quite a bit more. Navicular BSIs are really challenging, not just because of that, but also because it has this region of avascularity and the dorsum in the center of it. So the lateral side of the navicular is supplied by the dorsalis pedis artery. The medial side is by the tibial artery. And there's this watershed region. And so because of that, it doesn't get a lot of blood supply in the dead center of it. Now, there's a lot of variability in the blood supply to the navicular. And you see that in some really nice anatomical studies looking at cadavers. But for the most part, it seems like the loads in this area are also quite complex as well. There's a lot of tension on the dorsal side of this bone. So the other part too is the midfoot's very complex. There's a lot of other structures there, and because of that, these get misdiagnosed for a long time. They get misdiagnosed as posterior tibialis tendinopathy. They get misdiagnosed as plantar fasciopathy, or just like a midfoot sprain, if you will. So the average time to diagnosis is around 6 months. So this is a long time. They get missed. A lot of times people think that there's something else. A lot of times the athlete is just kind of dealing with some midfoot pain and it kind of puts it off for a while. And then of course, the whole time, these BSIs are progressing. And we know that the higher grade navicular BSI takes longer to recover and get back to sport. So ideally, you want to catch these before you get any sort of cortical disruption of the bone, and when it's still technically this stress reaction, if you will. And that's the best time to catch those, of course. But unfortunately, they're not caught that early. And so there's some really interesting differences, I think, from between Australia and the United States. It seems like a lot of the naviculars that I see here are kind of the higher grade ones. So these type 1, type 2, and type 3, we're actually seeing some cortical disruption. I know when I've spoken with clinicians in Australia, they often are caught a little bit earlier when they're type 0.5, which just means there's no cortical disruption. You see a lot of bone marrow edema that you can see quite readily on MRI, for instance. But so I think there are some regional differences there as well. And then because it's just not a very common injury, there isn't like really any standard practice really. There's no randomized control trial on how like best practices for treating these. When it comes to the surgery, there's a lot of disagreement on how we should even treat these from a surgical standpoint, whether we should do surgery on them or not. And so there's just a high amount of variability in practice. And I think hopefully that'll only get better as we move forward. And I think that's just going to take some time.
Yeah, okay. You sort of touched a little bit there, so let's maybe look to what can I utilize? What do I have as a clinician to try and pick this up early? So I guess some objective signs that are maybe suggesting that I can really hone in and pay some attention to. And secondary to that is, I guess, if I was suspicious, what sort of imaging do I go for then? And we'll maybe chat through from there how that might inform our practice into some examples.
Yeah, well, yeah, these are all really, really important questions. And I think I think with any physical examination, that should always start with kind of your diagnostic funnel, if you will. So you should always start with risk factors and mechanism of injury. So knowing who gets these type of injuries is really critical. So we see this injury a lot in runners. We see it a lot in sprinters. We see it a lot in jumpers as well. So the running, jumping, and sprinting athlete is going to be greater likelihood of getting this injury. So that's, of course, we want to start there. Athletes have vitamin D insufficiency, persistent corticosteroid use will increase the risk of experiencing these injuries. And it's important for the clinician to realize that it's not just injectable corticosteroids or oral corticosteroids. It can also be inhaled corticosteroids when it comes to asthma medications. So all those things will impair bone turnover. The pes planus foot will also increase the risk as well. And one of the big reasons why the jumping athlete or sprinting athlete is going to be a greater risk for these injuries is because those athletes will be more explosive. And so the more explosive athlete will experience greater bone stress, but also bone damage. And it takes longer to recover from that bone damage. And so the more explosive the athlete, the greater likelihood that they're going to be getting this. And the other risk factor that we always need to talk about when it comes to bone stress injuries is low energy availability, which is often termed relative energy deficiency in sport, or REDS. And so it's really important to be screening the athlete for that as well. So those are going to be like your main risk factors. When you look at, there are certain foot structures as well that will increase the risk of this injury. So a Morton's foot structure increases the risk, and that's because, so Morton's foot structure is where you have a second metatarsal that is longer than the first. And what that does is it really kind of focuses a lot of the compressive forces on this navicular, and that will cause some dorsal doming, if you will, kind of compresses it. So, and that occurs mostly when we're pushing off. And so about 86% of all athletes who have a navicular BSI will have pain when they're pushing off the ground. And that's because that foot is becoming a little bit more rigid. We're getting a lot of kind of compressive forces proximally and compressive forces distally, and they're all kind of coalescing onto this tibia, or not tibia, but the navicular, and it's causing this dorsal doming, and we're getting tension on the dorsal side of that, and that's where that BSI will start. So these start on the dorsal side, and the crack will propagate to the plantar aspect. So they always kind of move in that direction. And so because of that, we will often see tenderness in this navicular spot. And so we see over 90% of all athletes, I think it's like 96%. So it's 96% sensitivity. For athletes who have a navicular BSI will have tenderness on that end spot or navicular spot. So we always need to make sure that you're checking for that. So screen for that. So if you see an athlete who has pain with single leg hopping, pain with pushing off, and then tenderness along the dorsum of that navicular, that's going to be a really good indication that person should get some imaging. And the best imaging for that is going to be an MRI. These are the navicular is a very complex bone. It's very irregularly shaped. And because of that, it doesn't show up very well on a standard radiograph. So those are probably not even really worth doing. So MRI is indicated for these. MRI has a pretty good sensitivity specificity, but it'll still miss a good number of these. And unfortunately, that's our best imaging modality. And so because of that, it's really important if you have a negative MRI to repeat the MRI after a month or so if the athlete is still having symptoms and you haven't been able to rule out other diagnoses. So along the way, it's important to rule out posterior tibialis tendinopathy, plantar heel pain or plantar fasciopathy, whichever term you prefer, some sort of tibial nerve injury or anything along those lines are going to be really important to also consider. But for me, whenever I have an athlete who has pain with pushing off, pain in that dorsum of that region, it's a navicular BSI until it's been ruled out. And so we take those very seriously. And the reason for that is that this is an injury that, if ignored, it can go on to a complete fracture. It happens quite frequently. And then it can also develop into avascular necrosis, which later on in life will lead to permanent, lasting, disability when it comes to someone's mobility. So it's important injuries to catch early. And unfortunately, as I mentioned, they are getting missed for at least 6 months in most cases.
Yeah. Now I'm keen to, I'm going to talk to, I guess, some of the surgical stuff shortly.
Mm-hmm.
But let's say now we've imaged, so I've presented to you and I've got pain with pushing off and pain on palpation, and you're suspecting a navicular pathology, and you've imaged and it's showing no cortical breach and bone edema within the navicular. So along that continuum of stress reaction. I think, as you mentioned, in Australia, you're sort of seeing them picked up earlier and maybe later. And I guess for these ones that are sort of in that zone that it's not a fracture, like how are you going about managing this in a runner? I guess what's your go-to approach here? Are you immediately offloading? Maybe they only have pain running and jumping, but they don't have pain walking. Are you still putting them in say a moon boot or a cast? And then how do you sort of navigate that sort of process through? It's a big question for a short podcast, but we'll see.
Yeah, of course. Yeah, well, I mean, I think first it's worth just kind of quickly going over the grading system. So there are a couple different grading systems that are out there. I think most people are familiar with the Fredrickson grading system. Again, there's some other ones that are available as well. But briefly, a grade 1 the Fredrickson scale is just periosteoedema. A grade 2 is going to be periosteoedema plus bone marrow edema, and a grade 3 is a little bit more of both of those. And then a grade 4 is going to have periosteoedema, bone marrow edema, and then cortical disruption. Now, when it comes to these navicular BSIs, they have their own classification system. And so the classification system is from Saxena, and that's the most common one. There are a couple of ones out there, but I think that's the most common one that you're going to encounter. So type 1 is going to be where the crack is there's just a small dorsal crack, if you will, in the cortex of the bone and the dorsum. A type 2 goes into the bone marrow edema, so it's going into perhaps almost halfway through, or more. And then type 3 is going to be a complete fracture. The type 0.5, which is what you're talking about, is just going to be bone marrow edema. There's no cortical disruption. If you want to kind of draw some parallels with that Fredrickson scale, that's going to be like a grade 2 or a grade 3 on the Fredrickson scale. So how to treat those? Yeah, so this is where, so it's I mean, for like a type 3, it's pretty much automatic. You need to do surgery for those. So those are a little bit more straightforward. These type 0.5s, if you will, are a little bit more controversial, and you'll see a lot more variability in practice with those. And my suggestion to clinicians is to treat these conservative and get after them, and don't think that you can, kind of cheat a little bit and not offload the athlete very much. And so what we tend to do, we go with a tall fracture boot, and so a tall walking boot. And the reason why you want to go with that is because you need to control posterior tibialis muscle forces, because that can apply some tension onto the bone, and that's can of course complicate healing. So you want to have this long fracture boot. You really want to be non-weight bearing, and so I know some will do partial weight bearing or even full weight bearing in that tall boot. But I think when you're doing that, you're still going to get a lot of posterior tibialis muscle activity and muscle forces. And so we know that muscle forces are what generates the most bone stress. We used to think that it was impact forces, but really it is the muscle forces that we need to control the most. So unfortunately, you really want to be non-weight bearing, and so you want to use like some way to offload the foot, whether it be like a scooter in this boot. So you don't want to just have the boot off. You need to have the boot on and also be non-weight bearing. Of course, unfortunately, the boot is there to control all those posterior tibialis forces. So for that type 0.5, you really want to be doing that until that navicular spot is no longer tender. And once that navicular spot is no longer tender, then you can start doing some loading with that athlete. It's tempting to cheat a little bit and start doing some activities and some loading before they lose this dorsal tenderness. But I would say, for tibial BSIs, we're starting to really push the envelope on how quickly we're loading these athletes, fibular BSIs. But this is considered to be a high risk bone stress injury, which means it is a high risk of being a non-union and has a very high risk of going on to complete fracture. And so because of that, and the long-term complications of having those, like this delayed union or complete fracture, are pretty high. So we really want to treat these pretty seriously. So I would say go more conservative. But that's basically how we will treat those. And again, I like to be a little bit more conservative, and I think sometimes that can be very difficult for the athlete, particularly if they know other athletes who have had other bone stress injuries, say for instance the tibia, where they're like, well, this person's in a walking boot and they can do weight bearing as tolerated. But unfortunately, it's really important to do some education with the athlete and the athlete's kind of circle, if you will, like their parents or coach, what have you, that like this period of time is really, really critical. The amount of time for these injuries that you want to be non-weight bearing is about 6 weeks. So it ends up being about 6 weeks. We see that the rate of non-union in the type 1, type 2, and type 3 goes up considerably if you're not in a non-weight bearing state when it comes to those first 6 weeks. And the return to play is also faster as well. And that's why I was saying, like, look, do you want to get back to playing sports a little quicker? Do you want to get back to your activities? Then you need to go non-weight bearing. Give this bone the best opportunity to heal. Don't think you can cheat it. I know a lot of the athletes I work with are quite exceptional athletes, but they might be very exceptional athletes, but they also have very normal physiologies. We have like the homeostasis is we're no one's immune to that, and because of that, the healing rates end up being pretty static. And so you're really looking at about 3 months return to sport for these type 0.5s. They can be 4 to 6 months for the type 1, type 2, and type 3. So it could be even longer, and some of those are even up to 9 months when it comes to return to sport for navicular BSI. And that is not from the time of injury, but from the time of diagnosis and when the intervention has started.
Yeah. Now, I think that conservative approach makes a lot of sense. When you said you'll wait until the dorsal tenderness is reduced to commence some loading, what do you mean by loading? I guess there, I'm assuming we're not impact loading, but is that when you start some loading within the muscle work? So let's call it some calf work or standing calf work. And I'll just throw in the second part to that question is, I guess, what reliance on that imaging? If yes, they had some objective signs, and then 2, they had some imaging findings, what reliance do you have on that MR to come back to your decision making around loading and running?
Yeah, so MRI is really helpful for the initial diagnosis. It's not so good for determining return to play. And the big reason for that, we see this in tibial BSIs and sacral BSIs as well, is that this bone marrow edema is going to stick around for a long period of time. So if you have someone who has one of the type 1, type 2, or type 3, where you're getting some true cortical disruption, a CT scan can be really helpful, because the CT scan is going to be able to image this navicular in 3 dimensions, and you can see that crack start to close up, and it'll close up from the plantar surface to the dorsal surface. And so for those type 1, type 2, and type 3, that's kind of what you're looking for. And so that repeat imaging, CT scan again is great. MRI can be really helpful too. And as long as you're kind of focusing mostly on that, on this closing of this cortex, if you will, this crack. For Saxena type 0.5, I think going by symptoms is probably going to be adequate. I think that's fine. If you want to do a repeat imaging to make sure that this BSIA has not progressed, so type 1, I think that's perhaps not a bad idea. And if you have access to that, I would encourage that. But obviously, a CT scan, you've got radiation. MRI, you don't. And so there are some risks that are associated with that. So, but the CT scan is really helpful for showing that rate of healing. And I think that's not a bad idea to be using that to help guide that. So coupling the CT scan plus your symptoms and examination for deciding return to sport for type 1, type 2, and type 3. And then for type 0.5, you can typically go off symptoms and ability to load.
Would you sending an athlete back to sport, let's call it a field sport here, or running with, let's say they've had the symptoms before and they've gone through that boot phase and rehab, and you did image, but there's still some bone edema. Like, I guess for me as a clinician, that makes me feel a bit more nervous. Like, I'm like, oh, okay, well, if they're running now and they've got a bit of bone edema, what's that going to be like in 2 months? Are they at greater risk to get injured again? With that, it probably leaves me a bit, vulnerable. And that's where it gets a bit confusing I'm sure, with like imaging and the findings, because we rely on it so heavily objectively at the start for diagnosis. But then, so yeah, how confident would you be with doing that? Obviously, you need to do it at times. And how would I encounter that?
Well, these are things we don't know. And I think that's going to be, I would, like always with imaging, I wouldn't look at it in isolation. I would look at it and this athlete's past history for other bone. If this is an athlete who still has persistent bone marrow edema, who has had a history of other BSIs, I would be even more conservative with returning this athlete. If the athlete, this is a kind of their only bone stress injury that they've experienced, then I would say, you need to be a little bit careful, because there's some really nice studies that are starting to show, particularly in the jumping athlete, so basketball players and volleyball players, we also see this in runners as well too, that they will have some asymptomatic bone marrow edema that is kind of thought to be more of a signal of bone turnover rather than a true bone pathology. So if you have bone marrow edema or something that doesn't have cortical disruption, that is there with the absence, like it doesn't have any symptoms, then I would say go with the symptoms part. Because when you see people, I've had several patients that have had, say for instance, like a sacral BSI or a navicular BSI, have gone back and had repeat imaging. You can still see this bone marrow edema even a year after they've made a return to sport. So this is where clinical judgment comes in. I think I think I would just be watching that person. I would pay a lot of attention to that bony tenderness and take a look at that. This is the only one that I really ever pay a lot of attention to when it comes to bony tenderness. So like tibia, for instance, I have athletes that have tibial BSIs that will persistently poke on these and keep them kind of sore. And I was like, just don't do that. Let's not get too worried about it. But navicular BSIs, I think it's a little bit different. You really want to pay attention to that bony tender. So I would be checking that quite frequently if it were me. And if you have any doubt, I would go to a period of deloading and just tell the athlete that, look, this just means that we're progressing you just as quickly as your physiology will support. And you just need to deload it a little bit to allow your physiology to catch back up. And then we're going to resume our loading and see how things go.
Yeah. I'm going to round out around talking, I guess, a bit of a management space in this type of scenario, and then we'll touch a little bit on the higher grade thing, injuries and something around surgical intervention. But just to sort of paint a bit of a picture, 6 weeks in the boot, you mentioned maybe on a scooter, so non-weight bearing, and dorsal tenderness cleared before we're doing any loading. So I guess, can you give me just one or two key things around when can I start doing some calf work? Because you talk around the muscle forces, so call that some seated soleus work or standing calf work in those weight-bearing positions. And when can I start doing some impact loading? So that is, I guess, some of our bone loading, so whether that's the hopping or the jumping aspect and moving through that, what guides me there?
Yeah, so when we have those type 0.5s, we'll start doing some intrinsic foot strengthening a little bit earlier. So we'll start off with doing that, and the reason is that your intrinsic foot muscle strength will help distribute the loads across the midfoot. So we'll start doing those quite early. Maybe around, for these type 0.5s, around 4 weeks. We'll start introducing some of those. And again, be very careful with symptoms, but generally people do just fine with that. Those will be non-weight bearing. So we'll start doing, some short foot exercises, working on, flexor hallucis longus control, flexor hallucis brevis control. And then from there, we'll start working into some full weight bearing, activities, also. But seated calf raises to start off with, We usually start those bilaterally, and then move them into doing them or unilateral. And then once we do that, then we can get them up into standing and start to do those. The navicular gets loaded the most, the more plantar flexion you go into. And so as you go into plantar flexion, that windlass mechanism is going to cause that midfoot to develop a lot of tension and compression. And so as you go up higher and higher and higher, you're going to get more and more compression across that navicular, and then that's going to cause that dorsal doming. And so because of that, it's going to be much safer to load that person in more intermediate ranges before you start getting up really high. And so be careful about going up there. And, really what you should start thinking about is that as I'm kind of going through this, you should really be thinking that, gosh, this sounds an awful lot like plantar fasciopathy rehab that I might do for a higher level athlete. And that's because the rehab looks exactly the same. I would load them in exactly the same manner. I would start doing some intrinsic foot strengthening. Initially, I would start getting them doing some strengthening activities with their shoe on. So I think doing that part is very important initially. Then gradually wean them out of the shoe. And we know that for extrinsic foot injuries, so like tibia or Achilles tendinopathy, we want to load them with the shoe on. Intrinsic injuries, so navicular BSI, plantar fasciopathy or whatever, we eventually want to start loading them with the shoe off. And the reason for that is that the intrinsic foot muscle activity and demand goes up considerably. And that's when your forces are going to be highest on this navicular or metatarsal or plantar fascia, whatever you are rehabbing. So that's the way we kind of do them. Is we'll start doing some intrinsic foot strengthening and non-weight bearing. We'll eventually get them up into standing. In the meanwhile, we're doing seated calf raises with shoe on. We'll move them to doing standing calf raises, again, shoe on. And then we will move them out of the shoe. We'll come down in weight. And then we will start then slowly progressing them up into more and more plantar flexion to get greater and greater loads on that. I would love to tell you that there's some criteria to start doing some plyometric loading with these athletes, but I think again, we don't know the answer to that. And I would love to tell you that I use something objective, but I often am gauging it more on the athlete, how they're responding to loads, and we'll start doing some jumping activities. I always start those off with doing some wall springs. So they've got their hands on the wall and they're working on springing up into plantar flexion. We'll start doing that in dorsiflexion, just some low grade plyometric activities. We'll eventually go from bilateral to unilateral. And then from there, I really like doing banded hops with athletes. So I'll use like a pull up assist band, and we'll have them do some hopping activities. And then eventually we'll get them off that into doing, some full weight bearing hopping activities, and eventually to forward hopping, which is going to be the greatest loads on this navicular. So that's kind of the overall progression on how we might do that. We'll be doing a lot of posterior tibialis strengthening as we go as well, which I think is a bit of initially we'll do some isolated strengthening on it, but as far as it's important to realize that the posterior tibialis, besides controlling rear foot eversion and forefoot abduction, it is also a plantar flexor. And so if you are working into loaded plantar flexion, you're going to be working this posterior tibialis, and so you're going to be getting a lot of loads on that navicular in that way as well too. So I think that kind of shows how we kind of will work on this. Once the athlete can tolerate plyometrics and they're doing some hopping at a negative hop test, then we'll start doing a gradual return back to jogging and then running, and then cutting will be one of the last things that they'll be doing.
Yep. Last one around management is, some of the work around bone loading and bone loading cycles. So I guess just around programming, would you, in this case, because I know, say, low risk bone stress injuries, I think you would, but would you still adhere to that? And I use the reference of, the 4 to 6 hours break in between some loading cycles to get an idea on how their response to the symptoms and reloading? Or do you prefer just to have a loading day, do the work, and then they have a day off and go again, and really give that element of space in between? How do you go about that?
Yeah, this is a great question. And I'll tell you, it's funny, I go back and look at some of my athletes' programs that I hang on to even from just a couple of months ago, and I find myself changing this quite a bit. And of course, again, I always do it on an individual basis. If I know the athlete has been on corticosteroids, if they have a history of low energy availability, we'll slow things down quite a bit as far as how much loading we're doing, the frequency loading. One of the most important things to keep in mind when it comes to bone stress injuries is that it is not a volume driven adaptation. It's a magnitude of loading driven adaptation. So high loads, and of course, those are going to be relative to what they've been experiencing. That's what's driving adaptation. So you don't need to do a lot of sets. It's much better to do a few high quality sets and do them a couple times a day. So we typically will do, for navicular BSIs, because the blood supply is not quite as good, we'll typically load these athletes 2 times per day. And not more than that. And with it, maybe they can do a third session. This is going to be for the elite athlete. They can do like some cross training for a third session. I always think it's a good idea for athletes to do at least 1 day, if not 2 days of no bone loading, so they can still do some sort of cross training. But that's what we've kind of moved more toward. For the athlete who has some sort of impaired physiological response to loading, again, this persistent corticosteroid use, low energy availability, something along those lines, we might just load those athletes 3 times per week. And so we will slow that down as far as the actual frequency of that. And that's kind of what I've kind of found seems to be like the best way to kind of do that is consider that if this is an athlete who's had multiple bone stress injuries, that's a great sign that there's something going on there from a physiology standpoint. And you don't even need to go get blood tests or anything like that to make that judgment of slowing things down.
Yeah. All right, mate. So comprehensive. I think people get so much out of this short episode of the information, and we're well aware that it's impossible to get all the key elements of information into this, but it's really good insights. I'm just going to swing back to a little bit around that early decision-making trio, I guess, when it comes to that management side of things, and probably touching back to the classification. When it comes to location of injury, so let's say I would classify into one of the higher grades, so cortical breach, but the location, which I don't think is as common, but let's say you mentioned that real dorsal aspect that doesn't get the blood supply. Do you see dorsal breaches into the cortex in other areas, like more distal, and does that change our thinking around our management? So for instance, in the dorsal, you'd say that qualifies as surgery. You said grade 3 or 4, that would be surgery, but if it's not in that exact position, would that still be a surgical candidate because it maybe has greater blood supply?
Yeah, I mean, it's not just, so we always classify these high risk bone stress injuries because they have a high risk of going on to non-union. And that's because of 2 different reasons. Typically, it's going to be either a region of low blood supply, which is going to be the case often with these navicular BSIs. But really the bigger issue are the very complex loads. So we've got a lot of torsional and tensile loads there. So I would always, and again, I say that because like some of the vascular studies have shown that there's a high level of variability there. And so I don't know. I think that the blood supply component is probably perhaps less of an issue than it comes to these high tensile loads. It just happens to be that this watershed region coincides with the region of the greatest tension on this dorsal aspect of the bone. So if you're seeing cortical disruption in this navicular BSI, to me, like when you look at that Saxena classification of type 1, type 2, and then type 3, it's pretty controversial whether or not to do surgery on type 1s. I think that when you look at them, they tend to have a faster return to sport when you look at, and most of the data is just on case series. So these are not well or high level of evidence papers. And so you typically see that, these type 2, type 3, if you're not doing surgery on those, only about 32% are showing cortical healing around 16 weeks versus if you do surgery around 16 weeks, a lot of these athletes are already making, the early steps of return to play after surgery. So I would say if you're working with the elite athlete, I think surgery is probably a better decision when it comes to these type 2 and type 3. That is usually done via 2 cannulated screws. For a type 1, it's usually going to be a single screw. And again, I'm starting to see more and more surgeons opt for surgery earlier. And with these type 1s, particularly for these elite athletes, the larger the foot, the greater these compressive forces are going to be. And that's why we see these injuries in basketball players so often, not just because they're better and higher jumpers, but also the foot is going to be bigger. So you've got this longer lever arm. And because of that, those forces are going to be a little bit harder to manage. Um, the one thing the one caveat I would say is there's a really nice paper in AGSM 2 years ago that was looking at adolescents who have these type 1s and type 2s, and they were managed mostly non-surgically. And so I do think that there's probably some age component that's going to be occurring there as well. So as you get into the older athlete, I think it may end up being, and this would be a great question to ask a surgeon who specializes in these injuries, is like that they may do better with surgery versus the younger athlete. Let's maybe avoid doing surgery initially and see if it's going to heal on its own. But yeah, again, back to your original question, if it's not in this kind of more traditional spot, I would be, I think it's okay, particularly if it's just like a type 1, to have a period of non-weight bearing and immobilization, re-image. If it hasn't shown radiological evidence of healing, I think that would be a good time to consider doing surgery. And that's probably what I would probably do for most of these that are going to be kind of these non-traditional sites. But I would say almost the vast majority of the ones that I've seen are in this very typical central dorsal region of the navicular. That's where you're going to see most of these.
Yeah, no, lovely. So I think you've also sort of answered part of that follow-up question around, what the surgery might entail, but also a little bit around those ones that do qualify for surgery. So I guess, yeah, anything we're seeing with a crack, you're probably finding return to play is quicker, easier, and a less risk of returning. And then obviously you need to balance that across where your athlete sits, both from an age and also professional standpoint to make a decision. Is that sort of fair to say? Is that sort of the information you've provided?
Yeah, I think so. I think one of the things I think is really quite important when it comes to these injuries is when you're thinking about the athlete, and I think there are a lot of great parallels when it comes to first-time shoulder dislocations, is that you have an athlete, for instance, who has a first-time shoulder dislocation. You're like, okay, well, it's the middle of the season. We're just going to go do some conservative rehab with them. And then they come back the next year and their season starts again, and then they redislocate and they end up losing 2 seasons. And I think for these navicular BSIs, I would say, just like first-time shoulder dislocations, to do surgical stabilization earlier with these athletes. I think with these athletes too, I think don't dilly-dally around too much, because these heal so slowly. If you have the athlete who has, and all athletes, whether you like it or not, have a shelf life when it comes to how long their career is going to be. I mean, we've all been there. Surgery might be, the way to go sooner rather than later. And I think, in other words, I think sometimes we often think of surgical versus non-surgical. I really like the fact that we've kind of moved away from this term or using the term conservative versus surgery, because I think sometimes the surgery can be more conservative than doing non-surgical. And then we see that with anterior tibial cortex BSIs, because that is a much different injury than posterior medial tibial BSIs. If there's cortical disruption there, I would say, and I've seen a lot of athletes try to get away without doing surgery with that injury. And I'm always like, go get it done, go get surgery done, because you're going to be able to get back so much faster, and it's going to be a much less of a headache. And I would say that seems to be the case when you look at the evidence when it comes to these navicular BSIs. You got a type 2 or type 3, and if you're type 1 and you're a higher level athlete, consider getting surgery rather than perhaps wasting or losing 2 seasons over the injury.
Beautiful, Rich, mate. So much information there. We really appreciate you coming on board and having a chat. Mate, you have some great resources out there that, we at SportsMap really advocate people looking at on Montana. Can you just tell us a bit about that?
Yeah, thanks, Nick. Yeah, we have two things. We have our Instagram page. It's going to be a little bit of a down as far as frequency, just because of summer, but we're going to start picking up here with posts. And so I think, if you want to learn a lot more about patellofemoral pain, the running athlete, the basketball athlete, Achilles tendinopathy, bone stress injuries, that's a great place to go. I also have an online course that you can access through montanarunninglab.com. And so our handle for our Instagram page is also Montana Running Lab. And even though I've moved to Ohio and I'm at Ohio State, we're going to keep it as Montana Running Lab. So I think it's easier for people to find. So those are going to be the best places. And of course, I hope you can come join us for our course in Boston. I'm looking forward to that. It should be a really great event. And it'd be great to see. But I know, there are a lot of, fantastic PTs who work with the running athlete who are in Boston. Boston's like one of the best running towns in the world. So we're looking for a great turnout.
Cool, mate. No, yeah, great resources out there for those continuing to learn. I think you can clearly see that just in this episode, you'll have so many takeaways. So, mate, we thank you. All the best with the new role at Ohio State. We look forward to seeing more work come from you and the team there. So, thanks for joining us, and we'll see you in Boston.
Thanks, Nick.